Assalamu alaikum and welcome back to another episode of What's Up, Doc. I'm your host, Dr. Alia Al-Barwani. It's been a while since our last episode, and we're really happy to have you back and to be back on our series and our episodes. So, What's Up, Doc is a production of Muslim Network TV, the only Muslim network broadcasting in North America. You can find us streaming 24/7 on Roku TV, Apple TV, Galaxy 19, and Fire TV. You can also catch us on our YouTube channel at youtube.com/Muslim Network TV and on our website at muslimnetwork.tv. Today, we're talking about hospice and home health care. According to the CDC, in 2015, they reported about 1.4 million patients were using hospice care or in hospice care. Yet it's something that we often don't talk about. It's something that we either feel too embarrassed to talk about or are really sad to talk about. And it's something that, as I said, if 1.4 million people are in this, we need to understand what it is and what it entails. So we're going to be talking about that today. Joining us in that discussion is Atif Fattah. Mr. Atif is an administrator of Fortune Healthcare Incorporated, a facility licensed for home health and hospice services since 2008 in the Houston area. Welcome. It's such a pleasure to have you.
Thank you for having me on. Assalamu alaikum.
So as I mentioned, hospice care is something as a physician that I have to talk about. Fortunately, not too often with my patients. I don't see a lot of really ill patients that need that, but it is a discussion for families to understand when they do have patients or family members who are ill. And especially in the Muslim community, it's something that we definitely don't understand and definitely don't like to talk about, in addition to home health care, which again is the topic that we're also going to be introducing and discussing today. So let's start with just explaining what home health care is and what is let's start with hospice care. What is that?
Well, hospice care is an excellent program that was created by Medicare and CMS back in 1940s and 50s. And this program is geared around the comfort and convenience of the patient, especially the patients that are diagnosed terminally ill. What it means that the illness that the patient is suffering, unfortunately, they determine that they will not last for more than 6 months of the time. That is just a determination, just like any other determination that can go wrong and have gone wrong. This program is designed by CMS to make sure that whatever time the patient has left on this earth has to be comfortable, convenient, and pain-free. And our whole service is geared around the comfort and convenience of the patient. Hospice at no point in time means that somebody has signed a death warrant, or it's just that there's a lot of time when diagnosis or illness of a patient has gotten to the point where no curative measure can do any positive impact on the condition of the patient. Is where the quality of life becomes more important than care itself, and that's when we come in as hospice agencies, and our whole sole job is geared around how much of a comfort that we can bring to the life of our patients, knowing very well that no curative measures can actually do any positive impact. As a matter of fact, most of the time, it has gotten to a point where medication or any kind of other form of cure creates more problems than the solution itself. And that's when hospice kicks in, and we try to make the lives of the quality of a life of a patient in a much better shape than what it is while they are receiving the cure.
Okay, so that's a very clear answer, and to condense a little bit of what you said, I'm hearing that this is a point in time when doctors or care team have determined that there's short amount of time or anticipated you can fully know or anticipate when someone's death. But when someone is terminally ill, meaning that the doctors think that they have 6 months, you mentioned, to live, at that point, the focus of their healthcare shifts from curative, trying to treat this patient to make them well again, to improving the quality of life in the days and the short time that they have left. Is that right?
That's correct. And I would like to make a small disclosure, if it's okay with you, that I'm not a medical doctor. And my job here is not to give any kind of a medical advice. For that, you guys are.
Of course.
I am here to explain the philosophy of the hospice and the programs and why hospice is important and why we do what we do. And that's pretty much what my expertise in this field.
Excellent. And you've been doing it for a long time, so you have a lot of expertise to share with us for sure. And I do agree that it's important that you mention that, because that individual decision to enter into hospice care should be between a patient and their physician. So I'm glad that you're not a physician here today, because we do want to talk about the aspects, the non-medical aspects behind hospice care, so that our audience understands what can be provided through the care and services that your company and similar companies provide. And so when we talk about hospice care, you've mentioned a few things there, like the timing, focusing on quality of life versus cure. What is the difference? It sounds very similar to palliative care, which is hospice and palliative care sometimes are used interchangeably. They are not the same thing, however. Can you explain to us a little bit about the difference between the two?
Sure. So palliative care, the only thing that is kind of like similar in hospice with hospice, as a matter of fact, is the comfort part. But the major difference between palliative care is the comfort and curative measures goes together. So a patient can also seek the curative measures while they are in palliative program to find the comfort levels while they are going through the process and stuff. In hospice, for that particular one diagnosis, a patient cannot receive any more of the curative measures because of the fact that it's been determined that those diagnoses are irreversible. So let me just tell you, for example, a patient has COPD, or a patient has Parkinson's disease, or a patient has Alzheimer's. So what happens is, a lot of times people have the misconception that because of the fact that a patient is in Alzheimer's or COPD or any other diagnosis under which the patient is admitted to hospice, the patient cannot get or make any curative measures for other comorbidities. For example, diabetes or hypertension, which is completely a false concept. The palliative care is a service in which not only a patient can proceed with the curative measures, but also enjoy some of the comfort cares, which is a part of hospice program. But with hospice, to answer that question, the hospice, once you are in hospice, only under the diagnosis in which you are admitted into hospice, you cannot seek any curative measures.
Thank you for clarifying that, because that is an important point. And of course, the diagnoses that you mentioned, you're talking when they're in the later stages of their COPD, Alzheimer's, et cetera, where they've deteriorated in health and thought to be terminal at that point. Because there are, the reason I want to distinguish that is because there are many patients with COPD, which is chronic obstructive pulmonary disease, that are functioning and able to live productive lives without needing to consider hospice. But when we're talking about extreme cases of sick cases, patients who are really sick, that's when we're talking about hospice care potentially for these patients.
Correct. Let me just give you an example so that the audience can understand it a little bit more than COPD might not be a best example for it. Let's talk about renal failure, right? So if a patient is in renal failure and they are receiving dialysis, then they can be under palliative care while they are receiving dialysis. But if a patient is at end-stage renal failure, and if they opt to choose to go through dialysis process, then they cannot be under hospice, but they can be under palliative care. Once they have decided that they had enough and that dialysis is not the route they want to take, then yes, they qualify for hospice. Same thing is any kind of cancer, may it very well be sarcoma or leukemia or non-Hodgkin's lymphoma or any kind of a cancer. If cancer has evolved inside the body to the point where we cannot pinpoint our curative measures to kind of like target that particular area in order for us to destroy the cancerous cells in that body, and it's been spread to the point where it's impossible almost, and chemotherapy is doing more damage because of it's not going into remission, and it's doing so much damage that the quality of life is at stake here. That's when the hospice kicks in. After all the curative measures are exhausted, that's when we come into the picture and say, okay, well, now the important question is, what is more important, to continue with the curative measures and providing them with chemotherapies or radiation therapies or gamma knife or cyber knife processes and stuff like that, we can say, a patient can say, I do not want to go through this pain and suffering anymore, and that's when they say, okay, I choose comfort and convenience over the curative measures, and that's when hospice comes in.
Thank you for clarifying that. And I think that with that example, we can see a little bit more clearly the difference. So as you said, palliative care can happen in conjunction with treatment. It's introducing comfort with treatment, as opposed to the hospice, where a patient has decided to, along with their healthcare team, that curative measures will no longer be pursued and that they want comfort measures only at that point.
Correct.
Another question about difference between the two, I think, revolves around the where it happens. So where can a person expect to receive hospice care services? Do they have to be admitted to the hospital, or may they do that from the comfort of their home?
No. So that's a great question. There are two different kinds of hospice services: an inpatient hospice services, and then there is an at-home hospice services. So basically, what happens is, an at-home hospice, it starts with an at-home hospice services in which a patient stays within the confinement of the comfort of their home or residence, wherever they choose to live, whether it be assisted living or a skilled nursing facility, or the comfort of their own home with their loved ones. The services are provided at their choice of residence. Then it comes to the inpatient hospital level. So there are levels, just like every other services in the medical field. There are short-term emergency care hospitals, and then there are LTACs, long-term care hospitals, and then there are stiff units and stuff like that. At the same token, hospice also have levels. So it starts from at home or at facility at residential setup, and if the condition of the patient cannot be managed at home or wherever they are, where will be adult care centers, or it could be assisted living or SNF units, where it cannot be controlled. The symptoms cannot be managed by the caretakers. May it very well be family members or other facilities. Then they are transferred into what is called an in-facility hospice, which is kind of like a hospital setting, where 24 hours of the services are available, nursing is available, and doctors are available right then and there to do sort of like a symptom management. Now remember, there is no cure. There is absolutely no curative measure. So all we do is symptom management. So if we get to the point where symptom management is not possible in a current setting, then they are sent into inpatient hospice services where normally they are at they're located hospitals use some of the swing back structures to create the inpatient hospice there. And then some independent facilities also that they provide inpatient hospice services.
Excellent. So it sounds like there are options. So and that's always good. Thank you for that. We're going to actually need to take a quick break here. And then when we come back, we'll continue this conversation about hospice and home health care. Please stay tuned. You're watching What's Up Doc on Muslim Network TV. We'll be back after this brief break.
There are 16 million children struggling with hunger in America. That's 1 in 5 daughters, sons, neighbors, and classmates who don't know where their next meal is coming from. Yet billions of pounds of good food go to waste every year. It's time we do something about it. Feeding America is a nationwide network of food banks that helps provide meals to millions of kids and families in need. Visit feedingamerica.org to help them feed even more. Together, we can solve hunger. Together, we're feeding America.
Something more than a birthday is happening here. Once you can see it, you can help. The sooner you recognize the signs of autism, the sooner you can make a lifetime of difference for your child. Start by answering a few simple questions at screenforautism.org.
Assalamu alaikum. Welcome back to What's Up Doc. I'm your host, Dr. Aalia Al-Barwani, and today we're joined by Mr. Atif Fattah. We have been talking about hospice care, and we're also going to be talking about home health care today. So in the introduction, I mentioned, Mr. Atif, about how hospice, the discussion of hospice care can be, I mentioned embarrassed, but really I meant emotional. It's a very emotional discussion, a very emotional topic to have with family. And so I'd like to just kind of talk about that aspect. I don't know how involved you are as an administrator in speaking with families about hospice care, but I imagine that there is some involvement on your end. And so I know that as a practicing physician, it is something that I have brought up with patients, but it's something that patients have brought up on their end as well. So I want to make it clear that this is something that can be brought up if the family is ready or thinks that the patient may need this service. I'd love to hear your thoughts on that.
That's a good question. As a administrator of a hospice agency, my involvement with the patient care is 100%. Not on a clinician aspect of it, but I'm kind of a quarterback. I have to be aware. I have to keep myself informed and aware regarding every single thing that is going into my patient's life, and I do not discount it for a cent. I am very hands-on to make sure that that this whole process is going as smoothly as possible. If you'd allow me, I would like to first. If you would allow me, I would like to first tell you a little bit about the common myths or misunderstandings as far as hospice care is concerned, if it's okay with you.
Yes, of course, please do.
Okay. So there is a myth, so to speak, that once you sign up for a hospice, that means that you have signed on a death warrant of your loved one, which is so far from the reality. That a huge amount of education is needed to provide it to the family members of the patients, to let them know that hospice does not mean death. As a matter of fact, it's completely opposite. Now, you as a doctor know very well that Allah subhanahu wa ta'ala has given a human body a great mechanism or system of rejuvenating themselves. The human body itself has an amazing fighting force against the outside influences. It may very well be in the form of viruses or cell degenerations or what have you. Allah has created a system inside our body that keep rejuvenating and keep providing body with strength. A lot of time what happens is that we go so deep into the curative measures, and we believe and feel that the curative measures is the only thing that would keep a patient alive, which is far from the truth. Okay, there are times when the medication or the procedures can help a patient immensely, but then there is a time when body has to have some kind of break from all these outside influences for body itself to create the antibody and antioxidants and the internal, even your own spiritual powers that would allow your body to recuperate. And that is the most important aspect of the hospice services here. I'll just give you an example. Let's say a person who is suffering from diabetes and they're taking a medication, some kind of a saxagliptin, that's just say Januvia or Januvia, right? And if you read the brochures and if you do a little bit of research about that particular drug, you will find out that with all the positives that they bring into your body, there are a lot of negatives that also is brought into your body. Okay, and once it gets to the point where the power of medication or curative measures cannot bring any positive influences inside your body, that does not necessarily means that it can also stop the negative influences of it. There's been times where the negative influences of that particular curative care takes over, and it's creating a havoc inside in the body of a patient. It's running amok and destroying whatever is left in there to the point where the body cannot sustain it anymore. And that's one of the biggest mistakes that not only the patient and the patient families do, but also a lot of MDs also not understanding the whole process also make that mistake. And they keep providing curative measures and they keep providing medications and they keep providing the chemotherapies and they keep going into it. And at some point in time, the medical doctor, and at no point in time I'm discounting the value of a medical doctor. There's some amazing doctors outside. At some point in time, they have to sit with the family member and say, okay, well, right now we are at a point where the curative measures are not going to bring anything positive inside the body of the patient, your loved ones, and that let's give the patient's body a little break from all the negative influences what curative measures are bringing, and allow the body. I have patients right now under my care that have been with me for over 2 years, and nobody could fathom that these patients would last for more than 3 to 4, 5, 6 months, but by taking a step back from curative measures and allowing their body to heal themselves, they are spending a pretty comfortable life as compared to what it used to be when they were constantly circling around, going back and forth from the hospital and whatnot. And that's one of the most important aspects that people need to understand. Hospice does not mean signing a death warrant. Hospice means a patient has now decided to give nature its time and use this route to see how the body would react towards staying away from the curative measures and definitely when it's also determined by the medical doctor and their expertise that hey, it's time for us to be able to give ourselves a little break, and that's the most important aspect of it. Now, as far as my part taking care of a patient is concerned, hospice is a whole process. I have a whole team. that provides various kinds of services. Is it okay for me to talk about it, or do you want to jump into it?
Yeah, I just want to jump in and comment on what you said. Definitely want to give credit to the story that you shared with us. And as you mentioned, and as I said earlier, when we determine patients who are suitable, usually it is people who have 6 months or less to live. But that doesn't mean that, like you said, that you're signing that death sentence, because people will live beyond medical expectations or other expectations. And so that's something to keep in mind, that it does not mean that you are going to die in that time period necessarily. And it also doesn't mean that you are committed to being in that hospice care for the entirety of whatever is remaining of your life. Should you choose to come out of hospice at any point, that is also your choice. I also want to express and underline that, because I feel like a lot of families I've talked to, and we've had to consider that for a loved one as well, that once you've made that decision to go into hospice care, that that's it, that's the end of the line. And now if you change your mind, you're out of luck. And so I want to make sure that that's also clear. And then I know that we are going to be running out of time. So I would love to talk a little bit about home health, because I know that's another service that your company provides. And it's another service that is really, really underutilized, in my opinion, in certain communities. And so I do want us to make sure that we do touch on that. So let's talk a little bit about that. Tell us a little bit about home health, what it is, and the services that your company provides or other companies provide. Similar.
Absolutely. So difference between the hospice and home health is the home health patients are not on the stage where we can say that their diagnosis is irreversible. They're still in the process of curative measures, but the most important qualification for a home health patient is the patient has to be homebound. Now, a lot of times we do not understand, we do not know exactly what is the definition of homebound is. So if you allow me, I would like to elaborate on it a little bit. So homebound does not mean that the patient is bedbound. There's a big difference between being bedbound and being homebound, right? So in the eyes of Medicare, a patient is homebound when their movements are restricted. And for patient to move around within the home setup or even outside the home setup, it needs a taxing effort for a patient to be able to move around. And taxing effort is the most important and the kind of like the main point here. What is taxing effort? We have to understand that a home health patient does not mean that the patient cannot drive around. And so that's also a myth that people do not understand. Patient can drive around. It's also restricted. The ability to drive themselves around is restricted. So is the patient homebound if he's going out for the movies or a couple of drinks with his friends, or they're going out for no, that's not homebound, because that's not taxing effort. But if patient can go actually to the doctor's office by driving themselves, that does not take them out of the homebound status. Patient can go to a family meeting, that does not take them out of the family status. Patient can go to grocery store, and that would not take him out. Mother's Day dinner, it would not take him out. So a patient, an MD has to establish a homebound status of the patient because of the fact that it was taking a taxing effort for a patient to move around with it. With home health, patient continues to take curative measures. The doctor, the MD, the primary care physician still is the quarterback. They still can go to the doctor's offices to get their regular checkups and all that stuff. And while they are getting all that, in order for the convenience of the patient and because of the physical limitations of the patient, the multiple array of services are provided to the patient at home. For example, skilled nursing services, where a nurse at least comes once or twice a week to make sure that all the vitals are in check and correct, and all the medication profile is intact. The patient is taking their medications on time. and whatnot, right? Then we provide physical therapy, occupational therapy, speech therapy, medical social worker services, HHA, home health aid services, to make the lives of the patient as convenient and as comfortable as possible while they are trying to recuperate from their illnesses, is what the home health philosophy is.
Excellent. Thank you so much for explaining that to us and breaking it down. As you mentioned, there are many different services that are available in that. And it's not to say that necessarily you will need all of those services, but again, options. It's really important to have options. And I love how you described what somebody who's homebound is, because that's a question I get a lot, actually. And so being able to leave the house on occasion doesn't make you not eligible, but it's that it takes, a community effort, or it takes quite a bit of coordination for you to be able to leave the house, makes it difficult. And these services are provided to help you to continue to be able to recover or to receive treatment, even though you are unable to make it to physical therapy or speech therapy, et cetera, all of these services that you mentioned. And we're going to wrap up here, but I do want to talk just before we end very briefly, if you can share who is eligible as far as, actually really payment, because that's another important part. So what I'm looking for is just Medicare, Medicaid, et cetera, self-pay. What is the expectation as far as coverage for hospice or home health?
Great. That's a very good question also. So first of all, it all depends on what kind of insurances a patient has. Medicare is the most comprehensive insurance known to the mankind. And I'm so proud to be a part of a country that our country is providing our citizens with one of the best, especially the ones who are in need, the senior citizen. Medicare is bar none the best insurance somebody can have in the United States of America or even outside. As far as Medicare is concerned, every single aspect of hospice is covered by Medicare. There are no deductibles. Patient has absolutely no participation on it, and so is home health. Okay, if the patient does not have Medicare, and a lot of other insurances out there also have home health benefits. So if a person is physically not 100%, and they have a lot of ailments, a lot of comorbidities and all that stuff, they should be very careful about choosing a healthcare plan that has home health benefits also, and hospice benefits into it. A lot of private insurances do provide with home health and hospice. And if you allow me, there's one thing I'll take about a minute, if it's okay with you, to elaborate on what we do when a patient is in hospice. And that's very important, because people don't realize. People think that the job of hospice is to get there, pump the patient up with the morphine, put him to sleep, and go.
Sure, if it'll take literally a minute, because we are out of time.
There's a whole team. There's a whole team that is assigned for a patient's care when it comes to the hospice. There is a 24-hour nursing services that is provided. There is a HHA services that is provided, home health aid services that is provided. There's a medical social worker, and there's a chaplain services that are provided. They would visit them at least once a month to make sure that all the benefits are being utilized and patient. Then after every 2 weeks, there is an IDT meeting that is held under my supervision with my director of nursing and my medical director, and we go through the whole plan of care of the patient for the last 15 days, and we create a new plan of care. So there's a whole team effort involved in it, and we watch our patients on daily basis. We make reports. Every single services are provided. They turn in their notes. Their notes are QA'd by my director of nursing, who is going to make sure that nothing is missed and brought it in front of the doctor, who is going to go through this and sign that plan of care. Without that signed plan of care, there is no implementation. So there's a whole team that is working behind the curtains to make sure that every single aspect of the patient's life, even to the point where if we see any kind of sign of a patient abuse or patient neglect, we are responsible to bring the government authorities into the middle and to make sure that the patient is taken very well care of. And it's I'm so proud, and I'm thankful to Allah subhanahu wa ta'ala for giving me the opportunity because it's just not a job. It's also a calling. It's a very fulfilling, and you of all the people know this as a doctor. It's very, very satisfying. It's a fulfilling job, and I'm thankful to Allah subhanahu wa ta'ala that I have the means to take care of people who cannot take care of themselves.
MashaAllah, I love the passion. It definitely is a calling when you are doing it, when you're working in a field that you feel passionate about. And, I'm sure your patients appreciate the passion that you bring to the job that you provide and the services you provide them. I love the holistic approach that you just described with respect to the services that you give to your patients. And so if anyone is interested in contacting or finding out more about Atif Fattah's institution, if you are in the Houston area, otherwise we did put a link for some options through Medicare website if you are looking for some services in your area. Thank you so much, Mr. Atif, for your time and sharing all of that amazing information and just really breaking barriers as far as talking about hospice and home healthcare, especially in our community.
And Aalia, just in the last note, no matter where you are in the United States of America, my number is 832-472-0309. That is 832-472-0309. You don't have to come under my services. You have any questions, any anxiety. I lost my mother 4 years ago. I'm here to help you. You can call me in the middle of the night. Wallahi, it would be a pleasure and an honor to guide you towards the right way and to assist you in any way, shape, or form possible. It would be a pleasure and an honor for me to do it.
Amazing. Thank you so much again, Mr. Atif. And thank you all for joining us on another episode of What's Up, Doc. I'm your host, Dr. Aalia Al-Barwani. I hope you'll join us next time on another episode. For in the meanwhile, you can watch all of our episodes on our website at muslimnetwork.tv and on our YouTube page, youtube.com/Muslim Network TV. Until next time, assalamu alaikum.